introduction. My name is Raghav, but everyone calls me Rags, so feel free. I think typical Aussie thing to have a nickname impressed upon you by the age of 5, so that's the one that stuck. I lead the Heidi Health team in the UK, so based in London, with our team also based in London and Manchester. And yeah, really excited to go through Heidi and product. What I'll do is I've got some slides to share, if that's all right, Laura, just to kind of summarize some of the things that I want to touch on. And then maybe we can just jump into the product and see it for ourselves. Let me know if you have any questions as we're going through this. More than happy to answer them as we go. Cool. Can someone just give me a shout if they can see my screen?
We can see the screen, yeah.
Great. Awesome. Thank you so much. So what I'll do is I will just go full screen so you can see. Cool. So what I'll do is I'll walk you through a few of the things that I think are important to touch on as part of the 30 minutes that I have. Obviously, starting off just with the product, also a bit of our kind of our scale and our use cases and where Heidi's currently been deployed. And then really excited to go through some case studies across a number of different settings. So primary care, secondary care, like outpatient settings, and also community health. Great. So I think just starting from scratch, just in case you weren't here before, but Heidi is an AI medical scribe or ambient voice technology or whatever you'd like to call it. And essentially what it does is it transcribes a visit. Then you select what template you want to have the output then structured into some kind of form. So a note, a letter, a kind of progress note, pre-op, whatever it might be. You can select those outputs within Heidi from that template. I'll show you exactly what this means in that kind of that real-time flow. But this is a kind of 1, 2, 3 step process that we like to describe our product with. I think the key thing that if I had to really bring together the product and all the features that we have, I think the key thing that drives everything that we do at Heidi is that no matter where we operate, so whether it's in the UK, whether it's in Australia, New Zealand, Canada, Germany, the one thing that seems to unify all clinicians around the world is that they all like to write slightly differently, or all like to document slightly differently. This is not a trite thing. It's a very, very important thing because of how almost sacred documentation is. Without, I guess, preaching to the choir, I think many people kind of get what I'm my drift is here. That documentation is how information is communicated to the patient. It's how it's communicated to peers. It's a form of memory that the clinician is committing to the medical record. And if you are unable to reflect all the idiosyncrasies that they have built as habits and they deem important, then we've seen it time and time again, clinicians just don't use the product. I mean, I think everyone is really excited by Ambient and the concept makes a lot of sense. You turn something on and it does a part of your job that you probably don't love to do. But we've seen it, like I said, time and time again, and no matter what deployment it is, if we can't reflect the use case and the style of that clinician, then people don't use it. And if people don't use it, then you don't see the benefits that you're hoping to see. So that's essentially how everything is kind of geared in our product. So that's why you have specialty templates. That's why you have context to upload information into prior to Heidi analyzing it. That's why you have Ask Heidi bar at the bottom. That's why you have a tailored voice section where you can set up how exactly you want the document to be generated. That's why you actually have different ways of transcribing the conversation, which calls a different large language model based on the kind of use case or how you'd like Heidi to generate information. And you can see a bit of like a video there that goes through some of those things. But again, like I said, we'll jump into the product and I can show you this live together. Great, and I think it's worth noting about different use cases and where Heidi can be deployed. So I guess the most obvious one is just on our website. You can sign up and jump on straight away, whatever website you'd like to use. So whether it's Chrome or Microsoft Edge, it works across the board. We also have our desktop app. So our desktop app enables a clinician to transcribe a conversation if they have headphones like I have here. So you don't have to download any audio. You can just use Heidi as a desktop app. It'll transcribe the system audio. So this is great for all of those kind of telephony visits, any kind of Teams meetings, virtual appointments, that's where kind of the desktop app really shines. And then finally, our mobile app. So our mobile app is primarily used for kind of inpatient settings and community health, where Heidi actually transcribes or captures the audio and locally caches it on the device in kind of low or no Wi-Fi zones. So this is incredibly valuable for those community healthcare settings where Wi-Fi is definitely a luxury. And so that's, again, where that kind of, that mode is best utilized. So yeah, whether it's an emergency or same-day emergency care units or district nursing, that's a really strong use case for the mobile app. Great, and then just on our kind of like our traction and some of the stats around the usage of Heidi, I think it's worth touching on this in a couple of ways. One, to just show you the different areas that Heidi's been deployed in, but I think it's also really worth highlighting what this scale gives us as almost a unique vantage point in understanding what is valuable for clinicians, departments, enterprises, and also how to deploy this in the most safe way when kind of clinical reality is always quite unique and variant. So yeah, I'd love to touch on both of those as we go through, but just a high level stats, we have around 240,000 clinicians across the world that have an account on Heidi. And last week alone, we transcribed 1.6 million consultations across the world. When we talk about a lot of the scale, I think it's really important to dovetail this with our clinical safety and our compliance. And obviously you've gone through some of the guidance as well. What I'd love to do actually, just after I finish this, I'll send over a website that goes through a lot of this in a lot more detail and a lot more eloquently than I will do it today. And I'll just send that in the chat so you can have a read over as well. And there'll be ways to reach out to our team if you want any more information. But I think it's really worth noting just on the point about traction and usage of Heidi. I think our philosophy is very much that build the most clinically safe product that we can, and then use the evidence base that we have generated through Heidi being used out in the world to then constantly iterate and refine the product to make it the most clinically effective and safe product that it can be in different environments. The reason why I say this is because we found, so we've been a company for quite a while, so around 5 years, and we've taken many different approaches to how we can build the best product. And a slightly, I guess, how would I put this? A slightly almost like revealing way of building a product is having it available for everyone to use, and then having that as the evidence generation for how a product will be deployed. And so that's the reason why I say it's quite revealing, is because there's no hiding what the product can do and what it can't do. It's available for everyone to see, and it's the approach that we found delivers the best results for the clinicians that use our product. So yeah, you've got some of this information here as well on the high level things, but like I said, I'll send you a link that's very targeted towards the guidance and all the things that you would have discussed earlier in this event today. Cool. And then just focusing on the UK, so there's around 60,000 clinicians, around I'd say probably 25% of them or 30% of them use it every week. Last month, we did around 1.6 million consultations just in the UK, and that's across all different settings, so primary care, secondary care, community health, mental health, and around 1 in 2 GPs have a Heidi account. So if you're going to a GP, or if you are a GP, there's a quite high chance that they have an account on Heidi. And obviously quite deployed across different NHS trusts, which I can go through very soon. Cool. Some case studies just to focus in on, I think, just to like really paint the picture and give you some high level stats on the evidence that we're generating today. It's actually worth noting as well, sorry, on the point about some of these case studies and the evidence generation, we are doing some very specific things with different organizations to analyze Heidi's use in live deployments. So you would have heard from Andy Noble just before from City Healthcare Partnership, so from the Jean Bishop Centre, and we're collaborating with the Health Innovation Network of Yorkshire and Humber, so the folks that organised this session, to evaluate Heidi's use. So that's completely independent, but it'll be working with a live deployment. And I think they've been using Heidi in their team for around 8-9 months, perhaps. And I think you would have heard from Niels as well from the University of Cambridge. So that's also where we're collaborating with them. So Heidi will be the scribe that they're seeing the usage of in real time with primary care clinics around their area. So yeah, we're really excited to collaborate on these kind of more deep dive evidence generation sessions where they're completely, I guess, independent from the work that we do ourselves. Cool. So this is just a bit of a high level overview of some of the deployments that we have at the moment, just to paint a bit of a picture on some of those stats. There's, I guess, 3 that I want to focus in on. So the first is modality partnership. So modality partnership are the largest GP partnership across the UK. There's around, I think, 53 or more GP practices where Heidi's been rolled out to. A lot of these stats were from the initial evaluation of Heidi, where they had a really kind of stringent protocol on how to deploy it, and we worked with them very closely on this. And some of the stats that they tracked as part of that pilot. So as you can see on the right-hand side, there was a 51% reduction in time spent in consult on documentation and 61% outside of that consultation. And there's a lot of those stats around quality and confidence in the notes. And just to note, these are all increases. So this is not 38% felt that their notes were of good quality. It was talking about the increase pre and post pilot. You've also got some quotes here from the team. This is actually going to be turned into a bit of an impact assessment that we'll be sharing very soon. So I'll be very excited to share that with the folks on this call. But yeah, that's very, very soon to be released. Similarly with CHCP, so I don't want to go too much into this because I know Andy's probably talked about this a little bit. And I know that a lot of this will come out as part of the collaboration with the Health Innovation Network, but this is a very varied setting within the Jean Bishop Centre. Some of their stats and some of the evaluation findings. But like I said, this is going to become a lot more robust as Heidi's analyzed as part of their kind of live business as usual processes. And then in an outpatient setting and in same-day emergency care setting, I wanted to highlight West Hertfordshire Teaching Hospitals Trust. So we piloted with them maybe towards the tail end of last year. And I think I wanted to focus on this in a particular angle, which is this research study that Dr. Dimitri has put together. So he's the CMIO of Watford General Hospital, so very large district hospital, and he evaluated Heidi's use in his same-day emergency care team. And so this was actually, he went through this as part of another Health Innovation Network event. I think it was with the East Midlands team. So maybe, I don't know if anyone's attended that, and they've doubled up on this event as well. But yeah, Dimitri went through this. Again, I think this is looking to be published very soon, but just to highlight some of the things, documentation time was cut by 86% for their team. But like I said, I don't want to steal Dimitri's thunder. I know he's already gone through this in a previous event, and we're very keen to have this published. Cool. I think the key thing about a lot of these case studies is that it's not just what the product does, but it's also about how you have all these wraparound services to deliver a delightful experience. And so this is some of the kind of industry average of activation in, I guess, more some of the markets that are more mature in terms of the deployment of this tech. So for example, the US. So yeah, I know I mentioned a lot about customizing Heidi and making sure that it is really fit for purpose and fit for that clinician. And what we do as a team is make sure that we do a really rigorous kind of implementation process to ensure that the kind of templates and the way that we train clinicians, the SOPs, are all completely bespoke for that organization. One side doesn't fit all in this arena, and even though that might not be the most like hyperscale way to do it, it's what we found to deliver the best outcomes. So it's what we do. Cool. And then just worth touching on some of the quality monitoring stuff. So we have real-time quality insights on our kind of monitoring framework, where it live streams all the kind of key stats that we like to track. and different kind of quality assurance pipelines to real-time assess quality. So we're actually analyzing sessions as they come about. We're able to deep dive into specific sessions once a clinician asks for us to, when we get the consent. So they'll send us the kind of encryption, and we'll be able to access the kind of metadata around that session to see things that went well and things that might not have gone so well. And then similarly, an escalation improvement loop, which is a really kind of well-defined process. So it goes through our medical knowledge team. So there's 3 NHS accredited clinical safety officers as part of the medical knowledge team. It's a team of around 15 to 20 across the UK and Australia. And their sole job, not to make it sound reductive, but their sole job is to make sure Heidi is outputting the things that it needs to or should. And so there's a very, very structured way that we deploy this in real time, and kind of goes through our ethos of how we can make sure that all the information that we get from the 1.6 million sessions that happened last month in the UK, how can we use all of that to make a better product for everyone? And I just want to quickly touch on, I think I'm tracking well for time. So I just wanted to touch on the kind of next act and what we hope for Heidi to achieve as a company. I don't want to go too deep into the details here, but I think the key thing that we believe is, I guess, the future of ambient voice technology is that we believe that there'll be almost like a third space for clinicians to be using a product that's not the EHR. So they'll be communicating with a patient in real time, in the real world, I guess, the physical world. You've got your EHR, which kind of is storing all that information. And then you've also got almost like an AI workbench, which will be able to make your job easier, but also deliver some of the work that you need to do. So at the moment, Heidi sits at the point of care, creating the consultation notes and the documents that I think you're pretty familiar with in terms of what an ambient voice technology platform does. Then what we've just released now actually is turning consults into tasks. So listening into the conversation and pulling out the tasks that the clinician has said that they're going to do with the patient. And then I guess stage 3 is how can you execute on those tasks? So with those tasks, I want to assign some to myself. I want to assign some to people within my team. And eventually, I want to assign some tasks for Heidi to do for me. So can you actually do this for me within an EPR? Or can you actually call the patient for me to book them in the next 2 weeks? Like I said, this is going to be a very, very kind of scaled deployment of the next stack. So I don't want to get too much into the details because this is still something that we're figuring out as a team with the clinicians that use our product. But I think I just want to paint the picture of what this technology can really achieve, and I guess get people excited about some of the things that are on the horizon that we're working on. Great, and yep, this is just a slide about tasks, but I'll show you this in the product. Awesome, so what I'll just do now is I will share my screen. 1 second. And I'll just go into the product. Great, so can everyone see my screen here? Yep, I see a nod from Laura. So yeah, cool, thank you so much. Great, thanks, Nick. Cool, so this is Heidi. What I'll just do is I'll give you a quick run through of some of the core features. So this was a conversation, I think I was working, so this was at the One Heart Clinic in London that use Heidi across their, I think there's 6 practices. And I was showing them a kind of conversation where I was pretending to have chest pain. So yeah, you can see the entire transcript here. What Heidi does actually is live transcribe this. So as the conversation's going in 3 to 5 second chunks, this audio is processed. So there's no actual audio that's stored. It's just this written transcript. And then this is stored on the clinician's account for as long as they want it to be stored for. So we are the data processor, not the controller. You remain the data controller, and you can select within Heidi, so within your preferences, how long that session is stored for. So whether it's 1 day or 7 days or 90 days, and this will be fixed across your team. So I can just show you within a team setting, if you're onboarding a practice or a department, you can tick automatic deletion of sessions and then set it for everyone, and that'll be hard set for everyone within the team. So I think Andy and the CHCP team, I think they have it at around 2 or 3 days. Some have it shorter, some have it a bit longer. It just depends on what fits for your use case as a data controller. There's also a few things here while I'm on this page to note. So different kind of team member role-based access control. So we've got administrators, clinicians, and assistants. So assistants are those who can kind of help with the administration of sessions, but they're not going to be transcribing the sessions on their own. Then you've obviously got clinicians, which is like, I guess, the normal seat on Heidi, and then administrators who can have total access across everything and set some of those team settings that I showed you. And I guess the purpose of this is, while it might not be the most exciting features in the world, it's a really important way to make sure that Heidi is deployed in the way that you feel is right for your organization. So MMFA, requiring patient consent, automatic deletion of sessions, being able to view different team sessions. These are all things that you have complete configurability over. And sorry about the dollars. This is an old account when I was still in Australia. So excuse the wrong currency there. Great, but then what Heidi does is after that transcript, it'll ask you to select a note template. So you've got a lot of different templates here, and this is my example. This is my kind of account, but you can see that we give you out of the box. So we'll give you example kind of SOAP notes or history and presenting complaint, and we'll give one for your specialty. So I've set up my account as a general practitioner. Then you've also got some document templates like patient explainers, ED admission, referral letters, all those kinds of things. So maybe as an example, I'll select the NHS GP consult. Sorry, I'll just reset this. NHS GP consult. So this is actually created by a GP in West Hertfordshire, I think he's based, and he uploaded this to the Heidi community, which I'll show you soon. And it's actually the most used community template in the world. So when we took over my Australian colleagues, I was very happy that day. But as you can see, Heidi's kind of created this note. There's a quick summary at the top. You've got the history section, and it goes through the patient's ideas, concerns, and expectations, past medical history, drug history, family history, social history, examination, impression, and the plan. And this was all pulled from that transcript. Now, what we mean by a template is this. So a template is essentially a way to instruct Heidi to do very specific things. So square brackets telling Heidi what to write, round brackets are telling Heidi how to write, so based on introductions, and everything else is verbatim text. Now this is a heavily guardrailed kind of product here. We've actually rolled out a feature. We've just started with our enterprise customers and then rolling it out to the rest, where Heidi, based on the NHS guidelines, will not let you create templates. So before we would kind of ring fence it, but now we're gonna blanket not allow certain templates to be created, just to make sure that we're falling directly within the use cases that the clinician is desiring. But yeah, as you can see, it's a great template created by a GP, and now he shared it with everyone within the community. So I'll just show you here. Yep, you can see it there. It's number one on the leaderboard, which is exciting. All right, so I'll just go back to Bob Smith. Great, and so this is some of the kind of style things that I was mentioning. So you've got a couple of ways to transcribe the conversation. Extended is perhaps for those more longer, complex sessions where Heidi will take a bit more time to analyze it, but it will be analyzed in a way that is probably more fit for that. You've also got different levels of voice. So this is kind of the style and the way that the information is structured. And then bullet points, quotes, abbreviations, all of these things you can configure on your own. Now for the back of this, I can create many things. Let's say I want to create a clinic letter back to the patient, and I can just see this template as well, just to see how it'll be created. So it'll be in this kind of structure. So I'll just do that here. So clinic letter back to patient. And now, again, based on that conversation, it's going to analyze the information and then structure it in a clinic letter to a patient format. Now, even beyond a template and the voice features that I just showed you, there's many ways to add information or customize it further. So let's say I wanted to dictate into a section. I can select this, and then it'll dictate into a particular box for me. As you can see here, it's just done that for me there. And this is where, if you need to add information, but you obviously don't want to type it out, you can just word for word dictate just into that section there. As you can see, there's a few things here that have popped up. There's find and replace. So I've actually set up DH as drug history. So every time there's DH, it turns it into drug history. So that's why even in the template, even though the template said DH, it has turned that into drug history for me. So I can just highlight that, click find and replace, and then do whatever I want to. Let's say DH is what actually I want now. I've changed my mind. Now I can replace that everywhere forever. And now Heidi will make sure that that is the way that drug history is reflected going forward. I can also create snippets. So let's say you have standard paragraphs that you want to insert into different sections, whether it's a standard risk and benefits paragraph, whether it's a standard kind of section of or like a smart phrase. If you're familiar with products like Dragon Medical One, that's also a way that you can do that by clicking a slash and then inserting the relevant snippet that you want. So as you can see, all of this, hopefully you can see, is geared towards how do we get Heidi to output exactly what that clinician wants, because at the end of the day, that's what we found is the core thing between having a good product and a not so good one. And as I mentioned, this is our task feature, so it's currently in beta and it's just being rolled out across the different groups that we have. What Heidi's done here is it's pulled in the tasks from that session. So as you can see, this one is a coordinate task, and you've got 5 different boxes here. You can see the evidence. So I'll get my PA to reach out and get this sorted. And so now you have a task list for this patient based on these categories. So you can see them all here. In a very similar way, we've built our codes system as well. So I've just turned off SNOMED, but we've got ICD-10 and SNOMED codes. And you can see them in high relevance, medium relevance, and low relevance. And once you've selected them, it'll be appended to the end of the note. So you can also see the evidence as well. Again, very similar way that we've designed this. This is not really precisely the same tech. It's something slightly different. I don't want to bore you with the details, but took a lot of time to make sure that this is appropriately exceeding all the benchmarks that we have. And so, yeah, it's something that we're really proud of. Awesome. Yeah, look, there's actually a lot of things, Heidi, that I don't think I'll really get to. So for example, some of this memory stuff and spelling and how you want to refer to the patient and the clinician, how you want to configure your teams, but I'm conscious of time. The one thing that I wanted to focus in on was integrations, because I think I saw a question in the chat just before about it. So we are going through the IM1 program. So it's an NHS England program to get integrated into both EMIS and System 1. Unfortunately, the queue is quite long. So we've actually been in the queue for probably over a year now, and hoping to get approved for that. So yes, we're working towards the integrations of both GP systems within secondary care. We're integrated into Epic, both through our UK site, so within Cambridge University Hospitals, but also our first integration was with the US site, so that's enabled us to get that up and running. Also integrated with Altera Sunrise, or Allscripts, you might know of them as, and then building out our first proof of concept for our Cerner integration with a site as well. So yeah, essentially integrations. For some of them, the timelines are frankly a bit out of our control, but we're doing everything that we can to make sure that we get integrated in the right way through the defined NHS England programs, or processes rather. Cool, but yeah, I'd really recommend anyone to just sign up and see Heidi in action for themselves with some mock consultations or mock patients, and also ensuring that you're doing all the things that are set out in the guidance to deploy it in kind of live settings. A lot of this we also support with, so with our DCB 029, so the clinical safety case report, our DPIA, both within the NHS England kind of structure, but also a separate one. All of these documents is just accessible both on our Trust Center, so you can see trust.heidihealth.com. Yeah, so you can see this actually live here, and you can see all the different certificates that we have. We're actually the only company in the world that has all of these kind of international ones and also the UK specific ones. And then all of these you can request to have access to, and this is basically just sent over. The reason we request is just so we know who's deploying the product in this way, and so we can make sure that we have that touch point. And as you can see, this is the link that I wanted to show you about the NHS England guidance. But this kind of goes into as much detail as you probably hoped for. Cool. Like I said, I'm conscious of time, and again, probably the best way to do it is just to try it out for yourself. So HeidiHealth.com, you'll be able to sign up and have a go at it. And please reach out to myself. I'll put my email address in the chat as well if you have any questions. Like I said, we've got a big team here in the UK, so don't worry, we won't be replying to you overnight, even though some of us would be in Australia. We'll get to you on the same time zone. Cool. Thank you so much.
Thanks, Rags. That was really comprehensive. Thank you. There are a few questions in the chat. If you have time to pick some of them up now, in terms of transcription in from different languages, how well the software recognises strong accents or dialogues, and then a note from Glenn around, have you looked at GP Connect as well as IM1?
Yeah, good question, Glenn. I think we scoped out both. I don't want to paraphrase our integrations team, but I think based on the use cases that we were hoping for, we selected the IM1 program to get integrated into. We're actually also going through the it's a mission on my part. We're also going through the partner API program with EMIS. Fortunately, TPP doesn't have a partner API program, so we're just doing that directly with EMIS as well. But I'll get back to you on the GP Connect stuff. Great, so I see MC says, how well does the software recognize strong accents and dialects? It's a really good question. So the way that Heidi actually works is it creates that core transcript, and then what it does is it has a large language model read over the transcript and essentially like make corrections. The reason why we do this is, I think, two reasons. One, because we started in Australia, it's a very, very, very diverse population, and also a lot of funny accents. And so traditional dictation or speech recognition was quite difficult for a lot of kind of hospitals. Like, for example, patient came back from Bali with an illness, would often write it out as like BARLEY. So that's why we have a large language model read over the transcript and then another one to structure the information. So strong accents should be completely fine in. Jason's got a question on different languages. So yes, Heidi can transcribe in different languages. I think we have around 26 that we have benchmarked and tested. Within our terms of use, the language translation feature must be used by someone who can ratify the output, so basically fluent in both. It's not a replacement for a translator. It's just it enables a clinician to transcribe in a language with a patient that they would usually be seeing if they're multilingual. And then Alice, do you know how many vendors are relying on copy and paste? I would say, to be honest, most are relying on copy and paste. There's obviously many that have integrated Heidi into their system, but I would say, yeah, many are using copy and paste. And then I've just seen Alison's at the top about describing GP patient telephone consultations. Yeah, so our desktop app can already do the digital telephony conversations. So yeah, it transcribes the system audio. So if it's just running on your computer, it'll just be able to transcribe that. With the other systems, it's definitely something we can look into as well. I think we've had a chat to a couple, and yeah, could be something on the horizon. So thanks for the idea, Alison.
Excellent. Thank you for covering those. Are there any questions from the room? Does anybody want to put a hand up and ask a question while Rags is here? I just had one, if that's okay. Oh, Vanessa, go for it.
Do I have time? Because you know my questions are usually lengthy, Laura, aren't they? Is somebody else rushing in? Have I got a minute?
Have a quick question, and then we'll move on.
It's sort of a lack of understanding, really. So you're saying you can just go onto the website and make an account and use this tool, yet we know that implementation of technologies like this are actually more protected. So what's your implementation journey been like so far with these NHS trusts, and how quickly, when they need to go through the documentation and the checks, how quickly can you implement?
Yeah, it's a really good question, actually, Vanessa. So when someone's jumping onto the product, there's a really, I guess, like structured process they go, both in terms of like the onboarding flow, but also the kind of communication that we send to a clinician based on what we know about them when they sign up. So like what they put in their specialty in their country and everything. In terms of how the deployment has gone with these different NHS organizations, it's, I'd probably say, if I had to categorize it, maybe like 3 stages or 4 stages. The first is obviously all the compliance. So all the documentation, DCB 0160, DPIAs, assessing our cybersecurity posture, all of those things. I guess different organizations usually have different focuses or key things that they really want some information on. And so we have an entire, like I said, we have 3 clinical safety officers and an entire compliance team that kind of goes through that journey with the organization. A lot of this might actually be quite out of the box as well. I know there's a lot of ICBs that we've collaborated with to create DPIAs that can be used as templates for their practices, and same with DPOs. So perhaps that's probably the first way that makes the process a little bit quicker. Then after that, we do a very, very structured rollout process where we call them alpha and beta rollouts. We like to use cool names, I suppose. So alpha and beta rollouts. Alpha is essentially like a really small group of clinicians that represent the larger group that we might roll out to. And that's where we make sure that the templates are all iterated, that we've built really clear SOPs, and that the training is going to be customized for whatever use case, if it needs to be customized. Sometimes it might be that we can leverage something else we've already done, but we like to go through like a really, I guess, structured 2-phase approach for that deployment. So there's alpha group, and then the beta group is then deploying with each team very specifically. So we deploy with each team, track the metrics and their utilization and all the different hazard logs that they might be implementing, and then make sure that anything is iterated and approved upon as we then scale out. So this process is exactly what we did with Andy Noble and the team at CHCP. We started with a really small group of clinicians, well, not really small group, but a small group of clinicians, built all those templates so that everyone has a great experience from day one, and then deployed in a structured way with each team. I have a few slides that I can send over. I'm conscious of time, but yeah, that's the process that we usually go through.
Can you just say how long that process actually takes in months, weeks, or whatever?
Yeah, it's a really good question. The compliance one's really hard to answer, because I think some trusts taken like maybe 3 months, whereas some have been really quick, like maybe 2 weeks. So the compliance stuff is usually, I guess, out of our hands in terms of how long it might take. The structured rollout process is, the first phase is anywhere between 2 to 4 weeks, and then the rest is just in a by needs basis. So it's usually like a 2-week deployment and another 2-week deployment as we go on, and they overlap as well. So yeah, I guess it depends on the organization size, but we just like to make sure we're doing things quick, but not missing anything as we go through that process.
Okay, thank you.
Thank you. I'm going to draw us to a close. Thank you very much for your time, and if you could put your contact details in the chat, I'm sure there'll be lots of questions to follow up with. Thank you very much. Our next presentation is from Dom from Tortus, who's about to join. Just before he comes on, we'll get to put a link to a mural screen in the chat rather than putting you into breakout groups later. So please do have a look at a couple of questions around support needs and further questions you might have, and please do record on there, and that'll save the kind of slipping out of the breakout rooms later. Thank you. So Dom, can I invite you to take the stage and give us an overview of Tortus?
Yeah, for sure. And thanks so much for the kind invite. So hello, I'm Dr. Dom Pimenta. I'm the CEO and co-founder of Tortus, NHS clinician, still practicing internal medicine, physician and cardiologist. I think what I'll do, I think we have 20 minutes. So I'll briefly run through a bit of slides, talk a bit more about the company and the approach, then we'll do a live demo, and then we can probably just jump into questions. A lot about the regulation stuff I think is quite important as well, so maybe we can cover the recent NHS England guidelines and some of the scale that we've got to. And also there's a question about telephone companies. We actually are integrated into Surgery Connect, so we can talk a bit more about our Exxon partnership for our primary care colleagues. If I jump into some slides to start with, share my screen here. And actually share a window might be more sensible. That's a bit better because that should present a bit more nice. Cool. Okay. So as I said, we are I think the only British company in this space. We started out about 2.5 years ago at Great Ormond Street and have since scaled up through the NHS with some of the first hospital rollouts in the country. But to where this story started and what our general mission is, it's a bit broader than just sort of Scribe. So here's an email from myself about 8 years ago, writing to Cerner and saying this is the fundamental problem that we're trying to solve. We started using PowerChart, but compared to traditional paper notes, has several drawbacks. Namely, the practical workflow of a ward round is heavily impeded. And I think the problem that we're really trying to solve is that the computer in the room is slowing us down as clinicians. And here's some really good data to show this is the case. Quantity of mouse clicks in the average electronic medical record system. This is actually Epic, which is pretty well optimized and one that we integrate with. But even so, sending a patient home from the ED, 227 clicks of the mouse. The average doctor is clicking the mouse about 4,000 times in the average shift. And as a consequence, about half of clinicians are burnt out. But we also can't go backwards because the system relies fundamentally now on data, everything from audit to codes to prospective monitoring of quality systems. And actually in the world of AI, the need for data goes up, not down. So the problem that we're trying to solve, and most companies in this space is the interface itself. So Tortus is an AI interface, a little bit beyond Scribe in terms of our ambition, but certainly what I'll be showing you today is our initial product, where we take the speech and turn it into the notes, documentations, clinical codes. And now that we're integrated into a bunch of systems, some downstream tasks as well, like sending messages and collecting data from systems, etc. We use a bunch of AI tools. We've been working in the space for quite some time, and we've also published a lot of evidence about how to do this safely. And that's a real, I think, differentiator for us. We think this technology is super powerful, but potentially also very dangerous. And we're actually very happy to see that. I think NHS England is aligning on that. And we can talk specifically around some of our safety measures, but actually a bit later. I'll skip past this and I'll show you a demo. So I don't know actually if we did this before with the previous presentation, but I like to do a live demo if we can do a quick one in 5 minutes. But I do need a patient volunteer if anybody would like to give me a fake patient history for 5 minutes. I'll slightly awkwardly leave the floor open for any volunteers.
You can use me if no one else is. Oh, here we go, Jason.
Jason, so very kind of you to volunteer. Hi, Jason. Can you hear me okay?
Yeah, I can hear you fine.
Yeah, very good. Okay, so let me show you Tortus. So a very simple interface, and there's a very good reason for that. So we are a class 1 medical device. We are on our way to class 2. Every single feature in the app requires a ton of validation, verification, evidence for how it works. So the user set here is very, very simple. We've also studied the cognitive load of using EHR systems, and actually we figured out that the more features there are, often actually it detracts from the experience for the clinician. So we're very limited in that sense, but we think this is the refined data set that most people actually really, really need. So to start a consultation and put the patient's details in here, say Jason. I'll say, hi, Jason, welcome back to my clinic. How can I help?
Hi, yeah, I was out playing football with the kids. I've been at Alton Towers, had a few beers, stopped at the pub on the way back, playing football in the beer garden, twisted my knee. I think my kneecap might have popped out. I pushed it down myself and it clicked back in, but since then it's been swollen. I can't sleep. It's very difficult to walk on. So I thought I'd drop in and see you.
Okay, no problem at all. Just tell me a bit more about the mechanism of injury. So if you remember, what were you doing at the time?
Playing football in the beer garden, and I was taking a kick at the ball, but I twisted my leg, trying to bend it like Beckham.
Yeah, I gotcha. And then you said you felt it pop out. Presumably that was pretty painful, and you've put it back in. How much can you move the knee now?
Probably about 70 degrees of motion over what I normally can. So I can probably bend about halfway. I can't squat, for example. It's too painful.
Okay. And when was this, sorry?
Last week on Friday.
Okay. And what have you done for it since? Ice, ibuprofen, anything that's worked?
Paras, ibuprofen, not much really. Just taking those as many as I can per day. But like I say, it wakes me up at night when I'm sleeping. It seems to be more swollen at night.
Yeah, gotcha. Is this, sorry, the right knee or the left knee?
Right knee.
Right knee, gotcha. Any problems with the foot? The foot going blue or cold or pins and needles?
No, everything's fine. It's just that achy pain in my knee.
Have you ever done this before? Any previous knee injuries?
Yeah, I did dislocate it once before back a couple of years ago now. Had to wear a leg brace for a couple of weeks. Had an X-ray, it was fine, but no other injuries since.
Gotcha. And that was the same knee?
Yeah, same kneecap.
Okay. And before that, you've never had dislocations. It's just the 2 times.
No,
Yeah.
I mean it cracks and pops and it sounds like Rice Krispies, but apart from that, it's fine.
Okay. How's your health otherwise? Do you have any other medical conditions?
Asthmatic. I've had a fusion of the L5S1.
Okay.
Back
What was
pain.
that? Oh, for back pain, sure.
Yeah,
And for the asthma, do you take an inhaler?
I do. Yeah, I've got salbutamol that I
Okay.
take as and when required.
Anything else?
That's it. That's it, pretty much.
Any drug allergies?
No, fine with all of those.
Yeah, sure. Anything running in the family at all? Specifically, any joint problems?
Just arthritis, I think. Just standard.
In the elderly, sort of.
Yeah, upper
Gotcha.
70s, you know.
Sure. And how tall are you?
I'm 6'2".
6'2". And how old are you?
I'm 52.
52. Okay. And any other problems in the past or in the family? Any valve problems or any sort of very hyperextensible people in the family or anything like that?
I'm double jointed, if that
Okay.
helps. So it might be to do with that, hypermobility or whatever it's called. But apart from cancer and heart conditions, no, nothing else in the family.
And what cancer and heart conditions run in the family, sorry?
Angina, granddad, father, cancer, granddad, mother.
Okay, we'll see how it goes with that one. And do you smoke at all?
Used to, gave up about 11 years ago when I had my daughter.
Gotcha. And how long have you smoked for before that?
20 years.
About 20 years. How many would you smoke a day, would you say?
Depends how stressed I was. So probably around about 16 cigarettes. So you can add your plus minus ratio to that. For
Yeah, it's about
truthfulness.
20 pack years. Okay.
Yeah.
And you mentioned drinking alcohol. How much would you drink over a week, would you say?
I have 2 children, so that's around about half a bottle of gin a week.
Makes about sense in terms of ratio, sure. Okay, great. I'm just going to examine you. So patient's well at rest. Heart rate is 80.
Ow, that hurts.
Oh, okay.
Just twisted my knee there.
I haven't yet got there yet, but sure. Blood pressure is 140/80. Temperature is 37.2. Respiratory rate is 20. Saturations are 97%. And cardiovascular examination, heart sounds 1+2+0. Lung base is clear. Abdomen soft, non-tender. An examination of the right knee. Diffusely swollen. Painful on palpation of the patella. Popliteal pulse is present, and so are the downstream pulses, tibial pulses, and good cat refill in the foot. Pain on extension to 70 degrees of flexion, 40 degrees of extension. I don't know, that's a bit too much. 10 degrees of extension, and some crepitation actually on flexion. Okay, well, I think you've done a bit of an injury here. Definitely dislocated it. May have got some ligamentous injury as a consequence. We should do an MRI of the knee. I'm going to give you some stronger painkillers, give you some cocodamol and some ibuprofen, and also a drug called lansoprazole to protect the stomach for a short course to make sure you don't get any stomach problems. I think because you've had recurrent dislocations, we should also get you an X-ray and get you seen by the orthopedics, and I might be able to get you into trauma clinic to get a quick opinion on that later in the week. Does that
Can I
sound
also
okay?
ask if that's okay? Because I do already take some medication, so I wasn't sure whether they're going to be sort of, ones I'm allowed to take. So I do take naproxen 200 milligrams twice daily, and also I've got amitriptyline 35 milligrams to take on an evening just for sort of back pain and the like, as well as some dihydrocodeine as when requested and when required. So I wasn't sure whether that's going to have anything to do with it.
Yeah, I mean, you're already taking a lot of those, so let's not give you any new meds. Keep on with those for now, and we'll get you seen by the orthopods. How about that?
Brilliant. Thank you very much.
All right, very good. I like that you tried to break it. Okay, so so first of all, it transcribes, obviously. So the way that the security data flows, I may as well talk to you through. They sit on the system. It's locally encrypted. You get the transcript back, I mean, more or less instantly now, and you can have a look. It's a medical model, but sometimes it'll make a few spelling mistakes here. So amitriptyline, got hydrocodone. And then that passes obviously through to generate the note. Very similar, we've got a bunch of templates in the back, I mean, hundreds and hundreds. You can create your own. We also create them for the organizational level, for the departmental level, and there's some support that we can give around designing that. Once the summary is done, then you can also generate notes and codes and downstream documentation. So we'll just wait for that to return. And there's also a dictation mode here as well. So you don't necessarily have to record the consultation. You can also use it in dictation mode to dictate a note, dictate a letter, and that will actually flow naturally into the note in the same way. And here we go. So this is my cardiology ultimate note. So it's going to be set up for cardiology, but let's have a little look. So patient information, Jason, chief complaint, right knee pain following twisting injury in beer garden last Friday. Kneecap popped out, self-reduced, but remained painful, especially at night. Patient 52-year-old male, so there's a bit more detail there, approximately 70 degrees of flexion, described as sounding like Rice Krispies, and previously had leg brace and x-ray, asthma and salbutamol, L5S1, captured the meds there that you described, taking amitriptyline 35 quite nicely, no drug allergies, angina, cancer, I think that's what you said. Former smoker, 6'2", 52, cardiovascular examination, right, no history of knee location, no paraseasonal weakness. Got the observations there, didn't talk about that. And then plan for MRI of right knee, X-ray of right knee. So took out that bit that we talked because we had the discussion, not changing the meds, and then discussing with orthopedics. Some codes here at the bottom, so you can sort of choose the codes and it will give you the relevant evidence of where that occurred in the note. We've also got ICD-10, OPCS, SNOMED, the ED coding system, and kind of build any coding system really, and we've deployed a couple of custom ones. So the A&E coding system, for example, is custom for George's. And then if you want to generate a letter, we have a bunch of templates. Let's say GP for referral to specialist would be a common one for this scenario. And again, these can be templated. Now, what you can't do, oh, that's interesting, is ask the LLM to do things. It's very heavily guardrailed because we can't allow users to sort of ask for diagnosis. That's a different class of medical device, describe management plans, or a bunch of other safety features. That's it really on the product side. As I said, and that's a sort of typical colleague letter. And it's also got some notes to the patient there at the bottom. So salbutamol, inhaler, naproxen sort of explanations. You can also create notes specifically to the patient. In terms of integrations, which I'm sure everybody will want to know about, we are integrated into Epic. We're actually doing the first rollouts in the Royal Devon Hospital and Great Ormond Street, so a bit beyond the prototype stage, as well as into Surgery Connect. So for our primary care offering, it's directly integrated to the telephone system, works for inbound potentially and outbound calls, so clinician, but also in the future receptionist calls as well, and gives you the same or very similar functionality. And we're sort of extending that features out now to be able to do more things with database information summarization from the system, as well as doing some downstream tasks specifically for Epic, but potentially with EMIS and some of the other EHRs later in the year. I think I'll probably pause there actually for questions rather than just talking slightly at random, and see what people would like to ask. Let's have a look. So are those bespoke integrations or using like standards like Fire HL7? So Epic is, you sort of have to be integrated to Epic. It's a vendor services agreement. I think it is Fire-based. Smart on Fire is the system, but it's actually a live API. So it writes live into the encounter. It doesn't write to the database. The assurance processes are the same actually for Exxon EMIS, so that's the IM1 system, and we've been quite in the insurance process for that already through our partner. And then Cerner, we use a third party generally, and again can spin that up in a relatively quick time, 4 to 6 weeks. Yeah, system one we should also be live very quickly through Exxon, probably in the next, hopefully next 4 to 6 weeks, depending if IM1 can get us through. And I think Rags mentioned that they are pretty inundated at the moment. Can Tortus guide the conversation to ensure all clinical questions are asked? Super good question. And I think that brings me on to clinical safety. So we are a class 1 medical device. We're on our way to being a class 2B pretty quickly and submitting to a notified body. We're very careful about what the system will suggest to you, and that includes, in fact, prompting. You can use templates to do red flag, templating, and we've seen that as part of a way of making sure that clinical questions are answered. We'll also have the capability of displaying the template during the consultation. So you can see as you go down which bits you've missed, which I think in particularly long or complex algorithmic consultations is pretty useful. In the future, we will have guidelines, but that's beyond class 2. And we'll be doing that quite soon as we've got those classifications. Can Tortus guide the conversation? Anything to avoid copy pasting, quite frankly? Yes, I do think copy and pasting is potentially one of the biggest risks to the system. Different patient, copy paste into the wrong system. If we had some more time, I could show you the integrations, but they're all closed loops. So Tortus launches from the EHR, it launches from Epic, it will launch from Surgery Connect, for example, and pull the patient details into it. And then when you finish that consultation, it automatically flows back. So it's a closed loop. And I think that will be the standard requirement, and that's also part of NHS England's requirements. How do we access Tortus? Yeah, so for primary care, it's through Exon. For any other setting, just contact me directly. We've implemented now, I think, in about 10 trusts. We've just finished the largest AVT trial in Europe. Those results will be out in a couple of weeks. 17,000 patients, primary care, secondary care, A&E, mental health, pediatrics. Findings looking pretty solid, 25% time saving basically across the board. New patients and outpatients specifically, 20% increase in productivity in A&E. Ambulance service in London now seeing 200 patients extra a day in the clinical hub. So there's some big productivity gains, but there'll be some evidence coming about that soon. Accents, yes, we did a formal testing. Again, requirements for medical device. So we actually synthesized accents and then retested the system based on those synthetic accents. No real degradation in anything except medication names, although this was a model back, so maybe that's better now. But we do say with intended use, you have to use closed loop communication. So repeat the medication names. And we should all be doing that anyway, because often patients and even doctors sometimes can't pronounce the medicines properly. Is there an app version? It's a web app, so you can use it anywhere. You can use it on your mobile. And you can also use it on a desktop. We also allow you to drag and drop recorded files. So one community trust doesn't have any internet. They've actually got their DPA signed to record their consultations as a file. Then they drop and process it when they get back to their home base. Actually, sorry, that's the same question. You can record locally without any internet connection. I've done this on a plane, for example. It will just upload whenever there's an internet connection to get it. Currently, all the AI models are only good enough, really, accuracy-wise, to run in the cloud. So they do require an internet connection, but it doesn't need to be continuous. And as I said, you can also save the audio file for later. If you're using it in a system in primary care that's linked to Surgery Connect, they've got the audio file in perpetuality anyway for telephone consultations. So actually, that's an easy one to go back and process whenever you can. Any further questions or anything else that anybody want to ask? I think I'm probably at time, aren't I, Laura?
You're okay with time, actually. You've got probably about 10 minutes. So there's something else.
Oh, I was running to 20 minutes. Oh, sorry. Okay, great. Even better. So what I want to talk about then is the NHS England guidelines. So yes, so Tortus meets all of those criteria. And there's a few specific ones that I think we're quite bullish on. So what I might do, there's one more question. Is this based on an API to an existing AI or is it proprietary? It's actually a mix. One of the things that we have proprietary built is a system for clinical evaluation. In fact, because I've got some time, I can walk you through some of the back-end stuff about how we do the safety. But one of the systems that we built is a proprietary monitoring model. So what we can do with every single note is show the organization the hallucination rate and the emission rate for that specific note. And that's 2 years of research. We just published that initial stage of that study in Nature Digital Medicine a couple of weeks ago. But what I might do as I talk is put that in the chat. And what that allows us to do is to monitor and in real time correct any errors in the system. But B, it allows us to use different models very quickly. So we're constantly updating models. This is the 9th speech-to-text model we've used in 2 years. I think we're using a mix of 2 models at the moment. And again, it's like the 8th version of that in the last 2 years. We're thinking about moving to proprietary models, but currently actually that hasn't been required, but we're fully GDPR compliant, zero data retention. We don't store any data at all, and therefore we don't actually train our own models because we don't need to. And we don't allow actually any storage in the system either. So it's 24 hours locally. There's nothing stored in the cloud at all. And that means you can't access your consultations, or somebody else can't access them from somebody else. It's debatable whether the usability versus security is a requirement, but we think it's a very big cybersecurity risk storing a bunch of transcripts somewhere else. And that's just the philosophy that we've taken. And actually, most of our implementations now are actually fully integrated. So the information saved in the EHR, it's not in Tortus at all. And that's something that we've taken a hard look at. In terms of the NHS England guidelines, yes, I just wanted to talk about that. Nick, I will come to your commercial question in 1 second. And just open up this document here. That's it. Where are we? Yeah, perfect. Let me share this document. It's always funny to look through my computer. It's such a mess. Great. Okay, so you've seen the NHS England guidelines that came out a couple of weeks ago about ambient voice technology. I think it's super important that A, stressing the compliance, but also some of the why. So there are some basic stuff. Obviously, we meet all of these criteria. Cyber Essentials Plus is a criteria. So just highlighting that one because the Cyber Essentials certification is self-certification, but Cyber Essentials Plus is an external audit. And I think that's why they're stressing that, which we hold. DPA and approval. You can't access Tortus anywhere. You can't sign up yourself. You have to have approval locally. And for any of our implementations, I'm actually really happy to say we don't have anyone using it who's not in an approved organization. And there's lots of reasons for not bypassing those. Clinical safety officers, we have 2. I am actually one of them. And we have a couple in the house as well as an external company. Encryption for sure, and then unsafe functionality. So you'll notice that Tortus doesn't allow you to interact directly with any chatbot. We're about to add a context feature, but it's super heavily guardrailed. You can't ask for diagnosis, you can't ask it for management plans or calculations, because all of that is a much higher level of medical device requirement. We'll probably get there at some point, but we need a lot more evidence and sort of clinical trial capability to demonstrate that. Integrations I talked about, we're kind of integrating to all the major ones and being supported with the assurance processes via Exxon to get into EMIS and System 1, which we're pretty hopeful we should have in a few weeks. And then translation. You can't translate in Tortus. The reason actually is not because the models aren't capable or it's not a capable system. In fact, any large language model today will give you an answer in 200 languages out of the box, and pretty well. And most speech-to-text models will also do that. But all of our system is predicated on clinical safety. So our hallucination detection system, our emission detection system, a lot of the other guardrails in the system, they only work in English. And until we've validated them in other languages, we won't allow you to use the system in any other language, simply because we don't know what the hallucination rate is in Spanish, for example, and what implications that might have on the downstream medical record. Yeah, medical device, I mentioned, we're class 1. We've submitted to a notified body already for class 2. And that's the class 1, as some of you might know, is self-certification, and 2A is when you actually submit to another body to sort of mark your homework, and that's what we are doing at the moment. Compliance-wise, talked about, and system integration talked about. Yeah, and then real-world evidence. So we've run the largest trial. The evidence is pretty good. The time savings are quite effective. We've seen big reductions in cognitive load, as well as clinician and patient experience, and obviously acceptance for many of you who use technology already is pretty high. And that's, yeah. So any questions about guidelines or any other questions? Now I do have a little bit of time left. I can answer those. Commercial model. Yeah. So in primary care, Tortus is actually only available through Surgery Connect. Now, if you don't use Exxon in primary care, it doesn't actually matter. You can still download and use the system. And I think they might be bundling some calls in that as well. So you get a sort of digital voice system, but also Tortus's capability. And then it's quite extended to be able to use it for the reception flow, potentially for some downstream communications directly from the system as well. And Sean said that's interesting. Language is actually a weirdly hard problem now in the world of large language models, and that's the irony, in that validating and evaluating is actually impossible to translate. We have to start from scratch. And that's why it's interesting academically, but painful commercially. In secondary care, we're on G Cloud 14. So it's a direct reward. All our tenders to date have been actually off that framework. We actually don't charge on the license model. We charge on usage because secondary care is much harder to track who's sitting in what seat and when they use it. So we have an hours per an hours per organization process model. And that's a minimum contract of £200,000, but there's lots of discounts for yearly use and how many hours you pre-buy up front and things like that. And yeah, happy to have a conversation with anybody that's thinking about bringing it to the org level. Yeah, that's where we are. Any other questions?
Vanessa.
I'm going to ask another implementation question.
Yeah, sure. Vanessa.
So we're speaking to a lot of these, well, a lot, there's not many about actually, of the vendor neutral platforms to sort of host any AI tools. And I know they will also host ambient voice technologies. And I wondered whether you'd had any experience of working with them yet, whether you see them as a positive or negative. The reason we see them as a positive is they become a sort of front door where trusts will be able to plug and play many different AI tools instead of going through that difficulty of implementation every time. So upskill me, tell me whether they're good or bad from your perspective.
I think the general principle, and actually as an AI academic, I'm quite supportive. I think it's a good idea. The problem is they're built for models. They're not built for products. So they're really built for radiology models where you plug an image, you send it for classification, it comes back. It's a very simple workflow. But from what I've shown you, and actually most of these vendors, like these are complex products. We won't be able to do that for a number of reasons, but one of them is about the medical device requirements. So we have to control the UI, we have to control how how the user approves where the buttons are. So for any other implementations, it's very simple. It's an embedded product. Everything in that box is the same, whether it's in Epic or Exon or EMIS or TPP, because all of our clinical safety requirements are embedded within that. And then the architecture of how it runs will change how the models perform. So if you have a system which, they have X GPU in Leeds and then they have another GPU in London, the same model will have different outputs if the underlying hardware is different. So there's lots of variables that you then struggle to control. But the biggest bit for us is we've built this clinical evaluation system. It doesn't just observe, it actually intervenes. And that requires us to be able to see at runtime the inference. Putting that into a hospital and then just letting you have at it, we can't then do our post-market surveillance and report back to the MHRA. So it doesn't actually work. But we're quite good at implementation. I think it's just it's a really nice idea. I just think from a product user medical device, like all the practical things, it just doesn't really work. You don't just want to observe lots of this stuff. You actually want to do something about it, and then you can't continuously iterate, unfortunately.
Okay, that's really helpful. Thank you.
Thank you so much. That theme of kind of continuous iteration has come out strongly today. So thank you so much. That was fascinating, particularly seeing that real world. I know Jason was playing the patient, but really helpful to see that and how it might work in practice. So a huge thank you. Are you happy to share details in case people want to follow up directly with kind of questions or queries?
100%.
Amazing.
I'll leave my email in the chat. All right, thanks so much.
Great. Thank you. So that leaves us 5 minutes until the start of the next presentation from AccuRx Scribe, which will start at 5:02. We'll just hold off because I think people might dial in specifically for this presentation. So if you do want to quickly stretch your legs or have a comfort break, please be back here at 5:02 when the next presentation will start. Thank you. And a reminder also just to, if you do have a spare moment, to click on the mural link. We'll put the link again into the chat to give us kind of feedback, thoughts around support needs or areas where you might implement AVT in Scribes. Thank you. Okay, welcome back. So our third demonstration is from AccuRx Scribe. So I'm hoping Ben, Vish and Miles are on the call and are able to give a demonstration. Are you there? Yes.
Absolutely, we'd love to.
Hi,
Great,
Laura.
thank you. Thank you.
Brilliant. Lovely to meet you all. I'm Ben, Partnerships Manager at AccuRx, and I'll hand over to Vish and Miles in a minute to introduce themselves when we get to the really good bit where they start to demo the product for you. Our aims for the kind of this next 30 minutes are threefold, really. We want to introduce you to AccuRx and our Ambient Scribe powered by Tandem. We want to show you how AccuRx Scribe works, and we want to make you aware of our free pilot offer and how you can access it. So, as I mentioned, AccuRx Scribe is powered by a company called Tandem, who we selected after running a kind of a thorough market engagement process earlier this year. And I kind of want to kick off with an interesting anecdote that they've provided to us from one of their earliest adopter sites in Sweden, because I'm sure a lot of the discussion today is focused on its kind of the potential for significant time savings with this new kind of AVT technology. But where they're rolling out across this provider, for 95% of clinicians, they were getting like significant reported time savings every single day. But there were like this stubborn kind of like 5%, let's say, that just showed no time savings at all. And when at the end of the pilot, they kind of went into this, these clinicians, and they had a chat with them to understand why that was. So, what was it about, their pathway or their consultations or the way the product worked that wasn't giving them the time savings? They actually found that these clinicians had just been saying they weren't getting time savings because they didn't want to admit that, I'm saving this time and maybe you can give me another 1 or 2 patients. And I think it's just kind of a really interesting starting point for this conversation, because when you reflect, you can kind of completely empathize with that. Year on year, the NHS is perpetually asked to deliver more and more with the same or less resources. This then conditions us to kind of ask how every single possible technological advancement will help us do more with less. And we're forever kind of trying to close that chasm between healthcare demand and constrained supply. And yet no technology really, not even ambient scribes, which are fantastic, will stem that volume of patients seeking help, and they're not going to kind of instantly magic up supply that doesn't exist today. But I think what they can offer is something much more profound. They can create breathing space for you and your colleagues. They can offer clinicians like a precious pause during a otherwise very intense day, or space to truly connect with a patient, to notice things that otherwise might have been missed, and maybe to probe on a medical or even a non-medical issue that might be the real cause of a patient's poor outcomes, today, next week, next month, next year. Or God forbid, actually, they might enable clinicians to go home on time, once in a while. And so at AccuRx, our hypothesis is that the real kind of cost savings and productivity benefits will not come from cramming 1 or 2 more patients into everyone's schedules, but from the space that AVTs and scribe technology can create within your organization to more fundamentally kind of transform the way care is delivered. I'm just going to share some slides very short slides to help support the next part. So here we go. So for those that aren't aware of AccuRx, we're a digital healthcare platform, and we're used by 97% of GP practices up and down the country, and hundreds of thousands of kind of secondary care staff every single week to communicate with and about their patients. So I'm just looking for my slide deck now. Here we go. Can you see that? Yes.
Yeah.
So, so we offer, two-way communication with patients, two-way communication between healthcare professionals, structured and customized patient data collecting, now this new ambient scribe technology, and a digital front door, or what we call a digital patient triage route into your service. And we think that using these tools, you can actually kind of create this more fundamental transformation by following some very kind of simple steps. Look at what activity is taking place currently and see how we can remove it. So anyone kind of familiar with Accurex in primary care, we've really helped to capture a lot of the inbound and then enable you to remove, like respond to it or deal with it or triage it out back to kind of other providers like community pharmacy without having to provide them an appointment in the first place. In secondary care, stuff like waiting list validation to make sure that these people still require care, or enabling you to collect information that sends patients straight to test rather than having that kind of obligatory first appointment. We want to support you to convert as many appointments as possible to kind of digital two-way asynchronous interactions. So, this could be sharing like normal test results. Where we work in Leicester, there was a pathway where patients were coming in for their scans every 12 weeks, and then they would be given another appointment for 96% of them to be told everything's fine. Why can't that be shared asynchronously? And then we want to support you kind of to streamline the appointments that do need to take place. So those are, can we help you collect information up front so that you can focus more on talking about the diagnosis and the plan with patients? Or can you use the scribe to allow you to complete your notation and your downward documentation even faster? So that kind of just gives you that little bit of flavor about kind of how we think about Scribe and why we wanted to bring it into our product, but also how else we can work with you to transform healthcare. I'm now going to pass over to Vish and Miles, who talk a bit more specifically about our Ambient Scribe.
Thanks, Ben. And lovely to meet you all today. My name's Vish. I'm part of the clinical team at Accurex, so clinician by background, but working with Accurex now to help make sure that the product that we deliver for our users maintains its clinical integrity. I'll just hand over to Miles quickly to just quickly introduce himself, and then we won't keep you too long away from the magic. So I'll hand over to Miles.
Oh, thanks, Vish. Lovely to meet everybody. So my name is Miles. I'm also a clinician by background. Like everyone else in the UK team at Tandem, we're all current or ex-doctors and really understand the pain points in healthcare. So I left as an EDSHO, fed up with the state of admin and note-taking, and I'm really passionate and excited to bring Scribe into the hands of all of you guys and share a little bit of the magic we've built today.
Great, thanks, Miles. And before we go into that demo, there's just a few things that I think is, always very relevant to talk about with a bit of housekeeping when it comes to Ambient Scribe, just to make everyone aware of a few key things. So as you can see on the screen there, it's Accurate Scribe powered by Tandem. Tandem is our trusted partner who we've chosen to bring this technology to the NHS. And when choosing that partner, we evaluated a range of leading providers. Tandem really stood out. 60% of their team across Europe, as Miles said, are clinicians, set a really high bar for clinical safety, privacy, and NHS compliance. They're ISO 27001 certified, GDPR compliant, so really, really trustworthy in doing that. And off the back of that, we at Accurex, we really welcome NHS England's guidance on ambient voice technology. And what we're really happy to say is Accurate Scribe powered by Tandem, already meets or exceeds all of those core requirements. We've got Class 1 medical device. We're pushing for Class 2A medical device with future functionality coming into play. We're DTAC ready, Cyber Essentials Plus certified, regular CREST approved penetration testing. We've got named clinical safety officers, so we're DCP 0129 compliant. We've also built resources that help organizations satisfy their DCP 0160 compliance as well. So really there to support teams on making sure that compliance assurance is in place. In a few other things, Accurate Scribe as well, what I really like about the way we've built our product is that we're already integrated with key clinical systems. That includes EMIS, System 1, Rio, CETO, PDS, Vision via NHS approved APIs. As an IM1 supplier, we support HL7 and FHIR standards, and really looking to support that full interoperability across all NHS healthcare organizations. We've also got NHS Mail single sign-on, so this is also fully supported within the platform as well. The other thing I wanted to, just talk about was implementation. Accurex as a company, we're 220 plus strong team that's deeply familiar with NHS workflows. We offer boots on the ground support for any new product, particularly Scribe that we're implementing on the ground. We've already rolled out Scribe to over 1,000 GP practices and NHS organizations, providing hands-on implementation along the way, training and transformation support. And the last thing I'm going to just talk about is this general concept of intelligent workflows. obviously ambient voice technology, when you look at a lot of what we're providing, what we're providing, lots of other suppliers are providing, there's a lot of similarities in terms of what's actually produced and the product itself. But what we do know is that Scribe itself can't exist in a silo. Creating a note or creating some documentation is just the first step of actually transforming someone's care journey. What matters is what you can actually do with that output. So why we're really excited about bringing a Scribe into Accurex is that it can actually deliver outputs in real time, generate a clinical letter, save that back to the record, message it directly to the patient using Accurex, or maybe message it directly to a GP or other healthcare professional at the same time, all within the same platform. There's also a mobile version of the platform that allow you to use Scribe on the go. So that's really useful, particularly in community settings or home visits or whatever it might be. So Scribe outputs really need to be integrated into that communication fabric of care so that you're not switching systems, you're not chasing admin, everything is joined up and delivered faster. So with that in mind, that's just a bit of an introduction. I'm just going to hand over to Miles, who's going to kickstart the actual demonstration. I'll hand over to you, Miles.
Brilliant. Thanks, Vish. Okay, I'm going to start with sharing my screen here. Okie doke. Brilliant. So can everyone see this?
Yes, we can see your screen.
Great. And are we including this green toolbar up here? Brilliant. Okay, great. So thanks so much for your time, everyone. Really excited to show you this. Just in terms of a quick rundown of what we're going to see in the demo. I know that we've got a mixed audience between some primary care and secondary care focused colleagues and a mixture of clinical and non-clinical. So what I'd like to do is basically just show you the workflow if I was a GP and I had a patient come in. And we'll do a pretty high acuity scenario where Vish gets to flex his acting skills a little bit and illustrate not only the kind of notes that we can generate, but also some of the downstream documentation that we can generate that's really important and can assist with things like high acuity handovers and ongoing patient care. Talk a little bit how that ties back into the communication platform. But we'll start off, and this should be a familiar sight to some of you. So I'm going to demo this in EMIS, where we have our full integration, but we have almost the exact same process in System 1. So when you sit down in your surgery and you're ready to go, you'll log into EMIS, you'll log into Accurex like many of you will probably already do, and that's it. There's no added steps to be able to use Scribe, so it's really user-friendly. You just need to open a patient within the patient record, and we've got a really deep, robust integration. And what that means is you don't need to be on this consultation screen for the saving to record to work. You could be looking at bloods, recent consultations, medications. As long as that patient is open in the background, you'll be able to save your consultation. When you're ready to launch Scribe, all you need to do is click on the microphone button up here, and you will be automatically signed on through your existing Accurex login. I'm just going to full screen the window here to make it easier for everyone to see. So first thing to accentuate, obviously, we've got a really user-friendly interface here. So Scribe is already launched. There's a big blue button encouraging you to get started and greeting you by name. So if I go ahead and get started, I'm going to go ahead and start the encounter. First thing to realize here is that you can see I've already started the encounter, but I'm still explaining how the product works to you. So we have a really sophisticated content filtration system with Scribe. Only the relevant bits of information will get pulled through into that eventual medical note, but we've also worked really hard to make sure that other things aren't excluded, like, for example, important bits of social history, etc. But you shouldn't have to pause and unpause continuously because the emphasis is to get you a really continuous, easy workflow that minimizes interventions so that you can focus on the patient. On the left side here, you can see all of your consultations from the last 30 days. So this syncs like immediately with our new mobile platform. So say, for example, you're out doing a few house visits and you scribe each one as soon as you get back to your surgery. Or indeed, if you're doing like house visiting in a secondary care setting and you get back to your laptop, all those consultations will be here ready for you to edit and then seamlessly save to record to help you remember all of those visits. It's worth saying at this point, I know you've seen several demos already, so I'm keen to also give you some tips and tricks from our experience with Scribe. Down here, there's an add additional text button. Now, if you've had a patient that's had a recent consultation or someone that you see very frequently with a complex history, or if you already use Accurex and you've sent out a survey or something like that, you can paste all of that information into this box, or you can dictate directly into it and then save it. And that context will go into the eventual note to kind of enrich like the quality of the final output. So generally, the more Scribe understands about what you're trying to achieve and what you're seeing the patient for, the better quality note you'll get. Similarly, this is a great time to just tell Scribe a bit about what's going on, what you're seeing the patient for. If you're in clinic and you've got some notes you're reading through, explain the recent investigations and bloods, etc. And that'll really help to increase the quality of the output and make sure that everything you want captured is captured. But without further ado, I think we'll jump into it. If Vish is ready, are you ready, Vish?
Yeah, all good.
Awesome. All right, so let's get started. So I'll say hi there. Good morning. My name's Dr. Miles. Thanks so much for coming into the surgery. Before we get started, I just want to let you know I'm using an ambient scribe today. It's going to listen to our conversation and then produce a medical note for me so that I can focus on you. Is that okay?
Yeah, that's fine. Absolutely.
Oh, brilliant. Thanks so much. Before we get started, can I confirm your name and your date of birth, please?
Yeah, so my name's Rowan Bean. Date of birth is 22nd of February 1973.
Okay, great. Thanks so much. Rowan, I'm just having a look at your triage form here. It looks like you've come in with chest pain. What's been going on?
Yeah, it's this tight pain in the middle of my chest. It started this morning while I was just watching some TV, and it lasted about 10 minutes. Then it started again about an hour ago, and it hasn't really stopped since.
Okay, gosh, I'm sorry to hear that. What does it feel like exactly?
It feels a bit like a heavy pressure. It's not really gone away. It's going down to my arm on the left side, my jaw. Yeah, it doesn't feel great.
Okay, I can understand that would be worrying. I mean, how bad's the pain on a scale of like 1 to 10, would you say?
Oh, feels pretty bad, doctor. It's probably about a 7 out of 10. Took some paracetamol, but it didn't really touch it.
Okay, I'm sorry. Have you been feeling like breathless or sweaty or feeling sick? Any other symptoms with it?
Probably all three. I've been sweating loads. Yeah.
Oh, okay. Have you felt dizzy or lightheaded or lost consciousness, anything like that?
No, nothing like that.
Okay. Is this the first time you ever had anything like this?
Yeah, I've never had something like this before.
Okay. Do you have any other medical problems? Are you on any regular medications or anything like that?
I've got high blood pressure, doctor, but I take a tablet called Ramipril for that.
Ramipril.
Yeah.
Okay. And are you a smoker or a drinker?
Yeah, I smoke about 10 a day. Have done for about 20 years or so, but yeah, I drink now and then, but not very often.
Okay. Any family history of heart problems, early heart attacks, anything like that?
Yeah, I thought you might ask. My dad had a heart attack in his 60s.
Your dad had a heart attack in his 60s. Okay. Listen, I'm a little bit concerned by this history, to be honest with you, Rowan. I think I'd just like to examine you quickly. I'm going to speak my findings aloud just so Scribe can pick it up. And while we're going, I'll just get an ECG done as well. So you'll have some sticky pads on your chest, okay?
Sure.
So we'll start off with some observations. We'll say you've got a pulse of 98, a blood pressure of 142/88, SATs of 96%. You've got normal cardiovascular examination with normal heart sounds. Your chest sounds clear from a respiratory perspective. We'll say we do an ECG here quickly, and we'll say I'll have a quick look at it. So Rowan, this ECG shows changes that suggest to me that your heart might not be getting enough oxygen. This looks to me, I don't want to worry you, but it looks to me like you might be having a heart attack.
Okay, I was worried that might be what's going on. Does it look really serious?
It may be. I think I need to call an ambulance and we need to get you straight to hospital. While you wait, I'm going to give you some aspirin and something under your tongue called GTN for the pain, and we'll monitor really closely here for you. I'm gonna call an ambulance and tell them that your ECG shows ST elevation in leads V2 to V5, and you've got cardiac sounding ongoing chest pain. I'm going to make sure to alert ED and the cath lab at the receiving hospital so we can get everything ready for you. Rowan, listen, it's really good that we were able to fit you in quickly and that you've come in. I want you to try and stay calm and stay still. We're going to look after you until the ambulance comes here. I want you to make sure if you start to feel dizzy or lightheaded, your shortness of breath gets worse, or if you start to feel any palpitations, I want you to let me know, okay?
Yeah, will do, doctor. Thank you.
Brilliant. Thanks so much. Okay, so that's the initial bit of the consultation done. It's worth saying at this point that we can pause, unpause the encounter later, and that can be a really powerful tool. So it's not as relevant in this consultation, but say you've got a more psychosocial consultation or there's some sort of sensitive findings, maybe safeguarding problems that you want to let Scribe know about, but not necessarily right in front of the patient. You can pause this and pick up this encounter later on after the patient's left the room. But once you're happy that you've said everything you want to say, we can click Finish and Create Note here. And this is going to populate one of our GP templates, which is built to integrate really well with EMIS and System 1. But we've got a variety of templates already built out across a load of specialties in secondary care, anywhere from outpatient clinics to allied health professional clinics, nurse-led clinics and GP, physiotherapists, mental health. So we've got a really wide offering. I'll just walk you through the note quickly so we can see how quality the output is. So we've got this chest pain that started this morning, lasting 10 minutes initially, and then recurring an hour before the consultation and being persistent since. Heavy pressure radiating to the left arm and jaw, 7 out of 10. Paracetamol didn't help, associated with sweating, breathlessness, and nausea, but you can see we've picked up the important negative symptoms here as well. So denies dizziness, lightheaded, loss of consciousness. And this is the first time the patient's had this before. We've got the history of high blood pressure, for which they're on Ramipril. We didn't give a dose. On the examination bit, one thing to show you here is that we've got these underlined phrases. So this is what populates essentially when you say that you've done a normal examination, and this is user customizable. So we can actually edit this and change it. So if you've got a certain way of saying like an examination is normal that you're used to putting in notes, like maybe you like just saying no added heart sounds, for example, you can change that and it'll remember it every time. That's how you like writing that. And then we've got our heart rate and SATs. We've got our blood pressure pulled through separately here because this is one of the things that we support, literally coding directly into the record with SNOMED coding, which we can do with our integration, the family history of a paternal heart attack, the smoking history, the comment, and then the plans. We've done our ECG with ST elevation, administered aspirin and GTN, etc. So what I want to show you before we get into anything else is the quick and powerful ways that you can edit the note. So the first one, obviously, is you can type directly into the box. So I could say, otherwise well recently, for example. You can also dictate directly into the box, which is a really powerful dictation powered by a well-trained medical automatic speech recognition model with a big dictionary of medical terms to pick up all those tricky acronyms and monoclonals that nobody knows how to pronounce. And then also we've got this add or adjust button down here where you can make sweeping changes to the note really quickly. So this is how I normally edit my notes. But you could say, for example, actually, can you add in that the patient has a history of type 2 diabetes for which they're on metformin? And can we add an allergy to penicillin? So you just pop that bit in here. When we're happy with it, we click the blue arrow, and then everything that changes will update in blue, so it's really clear. So you can say we've now got our type 2 diabetic history with metformin, and we've got a pen allergy down here. You can also make changes to structure with this if you want, say, the history in bullet points with something more acute, etc. So we're happy with the note here. But our project doesn't end with generating a note. So the next thing to talk about is some of the downstream documentation that we can produce using Scribe. So this is a high acuity situation. So maybe I want to send the patient along with a letter that they can take to A&E so it's really clear what's happened. And the ambulance is getting it quickly so I don't have time to type it. So I can generate an urgent letter, which will go through the patient actions with some of the safety netting advice I gave them, what I'm worried about in acute MI, based on ECG findings and clinical presentation, the ECG we performed, a bit about the patient, and then the summary. So I saw this man today, what's happened, examination, etc. Also, maybe I'm calling up A&E and I want to alert them to the patient that I'm sending in. I could generate an SBAR handover report here, so it's really clear what I need to say and send them in with this. This is also really poignant in secondary care. We've done some paramedic service demos, for example, for this, where we're generating ambulance handovers. But you can see we've got a similar really structured output here with the assessment that we did. And some of the ongoing recommendations. And we can also generate text messages, etc., for the patient with what happened. Before we get into the AccuRx Omicomms bit, I just want to show you the party piece of this, which is really our integration. So I finished my note here, and I don't have time to sort out all the formatting from copying and pasting it. I click Save to Record here. It's going to pop up and confirm the correct patient, which this is, Rowan Bean. I'm going to click Save to Record, and I'll pop back into Enos. And just like if a colleague had edited the notes while you were looking at it, we'll get a little alert up here that the record's been updated, and then boom, in the EPR correctly in history section, examination section, we've got SNOMED coded blood pressure report in there correctly, comment plan, and everything is in its correct place. It's not just dumped, copy and pasted in a text box. And we're looking to start introducing searchable problem codes in the next few months as well to let you problem code from Scribe. Before we finish off, I just want to bring us back to the text message, and I'm going to hand over to Vish a little bit to talk about how these documents tie in with the wider AccuRx piece.
Thanks, Miles, and I'll make sure we get onto questions very soon, because I'm sure there might be some coming through, particularly when it comes to embedding Scribe within the AccuRx platform. As I said earlier, we don't want it to be this siloed tool that you just create a Scribe, you don't really know what to do with it. So Miles has shown you how you can get that into the record, but you can also do onward communication with it. So say, for example, this particular message, you wanted to ping a message off to Rowan as he leaves the GP practice. You can just click Message Patient from the AccuRx toolbar. It populates straight away from the patient record, so you can send that message directly directly to them. So that's really, really helpful. The other thing you can also do, say, for example, you created an urgent letter and you want to send that to your local GP, the local A&E, you can literally just click on the app button there, which is our AccuMail feature that allows you to send onward communications to other healthcare professionals in the NHS. So you can literally populate that message to send them directly rather than having to print off a letter and ping that over to them as well. So that's what really we're trying to build with putting Scribe into the tool is, yes, Scribe is great, it's amazing, it's going to create a huge amount of benefit, but how can we unlock really, really quick actions off the back of that that are seamless and within the same platform? So I hope that's clear. Thank you so much for allowing us to demonstrate. Yeah, happy to hand back to Ben. I think you're on mute, Ben. You might still be on mute.
That's that traditional problem of having too many windows open there. Thanks both. I was just going to share one final thing before we open the floor to any discussion, is that we are currently offering free pilots of AccuRx Scribe to secondary care organisations. For those of you that work in primary care, you'll know that we have also extended this to primary care. And so, yeah, if you'd like to try it out in your organisation, we started kind of from a standard position of 3 months free trial, but as part of that, you'll get boots on the ground implementation support to roll out. You'll have complete transparency on future costings, and if you want access to the wider suite of AccuRx functionality, you can have it. And I'll just pop a little link in the chat for you to register your interest if you so wish to discuss that with us. But you can also reach out over email, and I'll put that in there as well. Thanks. So, any questions?
There's a couple in the chat. Oh, sorry, Vish, you're on mute. Do you want to?
That's me doing it now. Yeah, I think there's a couple in the chat. Ben, I'll just check if there's any on the Q&A that we need to pick up. First one was, and this might be one for you, Miles. Can it be set up with more complex templates, or does it just work with the basic EMIS and System 1 GP consultations?
So I think the first thing I'll answer both versions of the way I could interpret this. I think the first thing you may be asking is within EMIS and System 1, if they've got custom templates, if we can work with those. So at the moment, we're still building out our template offering, and the approach that we're taking is mirroring the existing EMIS System 1 templates you might have. So for example, we've got a few like asthma nurse clinics that are running GP that we've built templates for, and integration for that at the moment is copying the box and then putting into that. Or alternatively, you can use our existing integration if you're happy to just have it go in that structure. But it won't if you want to go into the existing EMIS template, so you've got it used for downstream stuff, it's being copied the specific fields into that template. If you mean more, do we have like more complex templates in other areas, like for other health professionals or specialty stuff? Yes, we do. We've got a large variety, and we can build really specific templates.
Thanks, Miles. And this may be one for you, Ben. We're an AccuRx GP practice users. I put my name down, however, not heard anything yet. What are the timescales? I'm sure there'll be a lot on the list.
Yeah, so I believe that the rollout has started this week, so you should be receive some kind of communication this week from them. But I'll note down your practice, and I'll just go and explore that with the team and get back to you. And then I see Nick Hamilton has asked about the current extent of adoption, use of AccuRx Scribe in the NHS. So in terms of AccuRx Scribe, it's been rolling out over the recent weeks to about 1,200 practices so far, I think, so GP practices. And we are also now rolling out across secondary care. So we've got a couple of official 3 official pilot sites, which for procurement reasons, some of them I can't mention at the moment, but 2 large teaching acute hospitals, one in the Midlands and one in the South East, and then also a community and mental health trust as well.
Yeah, and I think an interesting point on the adoption piece in one of those trusts that we were piloting in, obviously, as you can imagine, with lots of pilots at the moment, multiple providers coming in and piloting at various different sites, which is absolutely the way to do it to settle on your best option. I think we were really happy that because of that implementation and transformation support we were able to offer, we were able to roll it out in a couple of weeks and get the most widespread usage across the trust of that particular platform. And I think that that speaks to how important implementation actually is. You can obviously build the tech, but you need to really support people in using it properly and and safely and sensibly. So yeah, really happy to share that as well. Laura, I think you've got your hand up.
Thanks. Yeah, just a quick question. You mentioned the content filtration system and the system taking out, I guess, bits of conversation that aren't relevant. Could you talk a bit more about how it does that and how you're assured the right things get into the consultation? And then just picking up on your implementation point, could you just talk about what does boots on the ground look like? What would people receive in a practice or a trust? What would they get?
Yeah, I'm happy to do both, or I'll do the first one and we can share the second part. So in terms of content filtration, basically what we do is, first of all, in terms of I guess there's two pieces. There's the transcription generation, so taking the raw speech input and turning it into like medicalized language. And then there's the second part, which is how we take the raw transcript and bring it into the notes. So we basically engineer on our side each section, telling it what sort of things should be included, what kind of things can be included, and trying to narrow down the scope to keep it relevant, but also allow details to be brought through that you would want brought through. So we control that on our side and do regular sort of like iterative testing, note reviews, etc., to make sure that there aren't any omissions and also that there's not like excess information being included. And we've improved that over the last couple of years now steadily. I think the main thing to say for the other part of that, where you say, if there isn't something being pulled through, or you want something else mentioned that wasn't mentioned, one of the things that I didn't actually show in that demo, but that we can do and is worth knowing, is that the notes and documents that are produced, once they're there, it's not like that's the end result. So that smart adjust button that I showed, the add or adjust one, that has access to the transcript, and you can give it instructions like, actually, can you talk a bit more about this? Because they talked about this and I didn't really feel that came through in the consultation. And it can restructure the note, make things more evident for you. So say for example, they came in and they talked a lot about their dog that had just recently died, and actually was really distressing to them and maybe didn't pull through into the medical parts of the consultation, and you want to say, this was quite important to them, can you pull it through into the social history? We can do that just by you asking for it. So there will inevitably be some times where you feel you would have mentioned this or you would have not mentioned this, and we work really hard to make sure it's as good from the get-go as we can at getting that match for you, but we've also worked to make it really easy for you to make those adjustments yourself.
Yeah, I think the thing I'll follow on from that as well, Miles, is the easiest way I sometimes describe it is if someone comes in and talks about the weather or the parking or whatnot. Like, it's really good at just filtering out that sort of stuff. So it's just like a bit of a delighter for users in that case. In the second question, Laura, was around what does boots on the ground implementation actually look like, which is a really good question. So as I mentioned earlier, we've got 220 person company. We've got a very formalized, structured customer success and implementation team that's basically situated across ICB and regions. So if you look, say, for Yorkshire and Humber, there'll be a customer success manager, there'll be an implementation manager who work directly with practices and organizations in that region to ensure that we're delivering Scribe as valuably as possible. That includes, yes, practice visits to come down and sit and talk through your challenges, webinars, one-to-one onboarding calls, tips and tricks, etc. Got was it 5 days a week or 6 days a week, Ben? I can't remember. We got our support team that if you get in touch with them, they'll respond back to you within 5 minutes.
It's 7 days a week now.
7 days a week. 7 days a week now. That's even I didn't know that. That's great. 7 days a week, you've got our support team where you can get in touch if you've got any problems, and they'll always get flagged to the right representative within the company to manage that region. When we talk about, say, bigger organizational deployments, say community trusts or secondary care organizations, that is literally, we will come and sit with you a day every couple of weeks to walk people through the platform, get it set up in the right areas. One of two reasons. One is we want to make sure you're successful. But secondly, it's a core principle at Accurx that all 220 people have to go on 1 or 2 practice or trust visits every 6 weeks, every 6 to 8 weeks. It's like a core part of how we're building it. That's the only way we're going to know how it's going to get better. So we almost see it as a good opportunity for us to come in and learn from you and see what else we need to be doing to improve our offering. So yeah, I hope that answers your question a bit, Laura.
There's and in the resources we provide, we've linked in the there's a bit more information about some of this as well. So, you'll have a transformation lead, you'll have a partnerships lead, you'll have a clinical lead that you work with, and then you'll have access to our data and behavioral science expertise as well within the company. So, and a technical/product lead. So, all of these people, you will see it at regular intervals, both virtually and face to face.
Fantastic. Thank you so much. Thanks to Ben, Miles and Vish. We really appreciate your time in the demonstration. Thank you very much. And hopefully everyone has seen the links, but we'll circulate them when we do kind of round up after the event. So thank you.
Perfect. Thank you all.
That brings us to our last but not least demonstration of the afternoon. So I'm hoping, I think I saw her on the screen, Amanda from RDI Inicio. Amanda, can I hand to you?
Yeah, of course. Thanks, Laura. I've got a couple of the team with us as well, in Amy and Mike, hopefully here too. Mike is going to share the slides for us as well, if that's okay. Or not.
That's okay. I can share the slides.
Oh, Amy, thank you.
Let me know. Can you see that?
On this slide. Yeah, perfect. Thanks, Amy. Laura, thank you. Thanks for inviting us along. I'll just start by introducing myself briefly, very quickly. Amanda Sparks, Chief Clinical Officer with RDI Inicio, formerly NHS lifer, some 27 years in the NHS, with a lot of that spent in around the surgical domain, finishing up. Oh, we're running through the slides there, Amy. I don't think even I could keep up with that.
Sorry, I'll sort that out.
That's all right, thank you.
You carry on.
But and essentially I mentioned the history as being important because it's where the seed for Flight Deck, which is a product we're going to speak about with you, was founded really, and that was in our journey. My last role there was at the Royal Free London as Director of Operations and Nursing, and whilst there we have the absolute privilege and unique once in career time journey of digitising a brand new hospital and taking it through on its HIMSS 7 journey, so that real high digital maturity. But in doing that journey and achieving that HIMSS level 7, something we learned very critically important was, one, how to bring your people along on a journey of transformation like that, but the importance of system learning, and how important that became in terms of moving from kind of this rear view mirror way of learning from incidents through to very much a proactive learning, and how data can enable that, and data-driven decisions can enable that faster. And that will fall into place as I go through and talk about Flight Deck and what it is. I'm going to wrap some context around, because I understand you've been hearing from others today. We are very much at an earlier stage in our life cycle as a product, but hopefully we'll keep the excitement going in terms of where we're at and what it's pointed at doing, and some of the problems that it's set to answer. Amy, are we good to go?
I'm just trying to.
We've had some issues all day between us, so apologies for this. Let me see if I can share again now. Bear with. There. Let me know if you are able to see my screen now.
It's coming. You can just see your initials at the moment. But yes, now we can see your screen.
And hopefully in presentation mode as well. Everything. So I think the heat's got to everything now. I've got a thumbs up from Nick. Can everyone else see that presentation? I can't see you guys now, so.
Yes, we can see the slide. It's not in present. Oh, it's about to come into presentation mode. Yeah, there it's there now.
Right, we're there. Okay, it's a wee bit slow. So I just wanted to start with that problem, the problem that we set out to solve, and not sure why it's doing that. So annoying. apologies if I'm preaching to the converted as well here, but just a few of those stats in terms of the problem that we're solving. So really understanding, oh, that's really not good, is it? Is that changing for you guys as well?
Yes, it is. It's flipping around a bit, but no, it seems to have settled now. So
hasn't it? So some of the problems we're looking at solving is really about avoiding that harm around unsafe care, the avoidable deaths each year, the costs associated with that as well. We have seen a little tipping down of never events as we've rocked through the last couple of years, but they're still far too high, with more than one a day across England at the moment, and a cost of 800 million to the NHS each year in terms of compensation. The problem we feel is, or certainly I do from my lived experience as well, that's more on the underreported, unseen side, is the impact that that's having. Thank you, Amy. The impact that's having on our staff and the wider ecosystem that sits around the patient. So the patient harm is an obvious one. But the second victim syndrome, so that impacts our workforce and the extended family, friends circle that sit around the patient as well. There's an awful lot of research, thankfully, now coming into the fore that really look at the impact it's having on our workforce, with nearly 80% reporting difficulties concentrating when they've been involved in either a serious incident or a never event. And actually, some of these symptoms vary from anything from more stressed at work and carrying that stress into work, right the way through to leaving the profession, leaving the trade, and sometimes even worse outcomes for our workforce, with examples of, unfortunately, self-harm and sometimes suicide across the professions of our MDT as a result of being involved in and potentially poorly supported after such events. There's also an awful lot of evidence that's banking up now around the fact that these risks could really be decreased significantly if staff perceived that their organisations were supporting them through the response to such an incident. An experience, again, from coming into nursing nearly 30 years ago, right up to present day, the way we're learning from never events and serious incidents really hasn't shifted. So it's still very much in that retrospective space. An incident occurs, a very long report, too long to read, is written. That takes 6 to 9 months to come out, with an action plan that sits behind it that's really quite one-dimensional, very static, and actually misses the salient points around the behaviours and the human factors that were involved or predicated at times those errors and incidences. Amy, if you don't mind moving on, if that's okay. There's a publication recently actually that just came out of the States where we also have a presence. The statistics are just absolutely harrowing for me as a clinician. I think anyone as a human, really, but 70% of the never events that are reported over in the States have a fatal outcome. It's an unbelievable piece of reading there, but essentially it's what our vision is to have that zero never event health system. They were named never events for a reason, I believe, and I really think we should be doing more in that learning space to surface the human factors impact and to be able to shift the dial in terms of how we learn and prevent going forward, as opposed to learn in that rearview mirror. If you don't mind changing again, Amy, thank you. We've done a lot of learning in healthcare from aviation. A lot, we think of SBAR, there's other tools that we are widely recognised within across healthcare now that have come from aviation. And I think the important thing to surface from some of those learnings is actually being able to capture the information in the first instance. And something aviation did very well once they introduced the flight deck recorder was be able to surface all of that conversation and decision making that's going on, and being able to learn from that going forward. I had an interesting conversation with a CCIO recently who's part of one of our pilot areas for flight deck, and we can learn from aviation, but the key difference and this was his view, quite well caught, I thought, is actually when you're on an aircraft, immediately the whole team is invested in the safety of that aircraft, because if something goes wrong, everybody is impacted. And the culture in our operating theatres and other spaces across healthcare is that it won't happen to me. I go home, there's no impact consequence outcome for me. And I want to really surface that yes, there is, and actually incidents in the operating theatre can be carried far wider than the team that are stood in the room at the time. But a well caught point there by one of our local CCIOs there. And as the important point is, We can only deal with this information and learn from it if we've caught it in the first instance. And right now, as we look across our operating theatres across the country, they are closed rooms in all senses of the word, in terms of what we're surfacing in terms of data coming from that room, and learning to surface the unwarranted variation that happens between theatres. These are highly protocolized areas, and it's still unbelievable to me the lack of standardization across theatres, even in the same theatre suite. So being able to surface what that variation is and learn from it, where is having the better outcomes, is really key. Next slide. Thanks, Amy. So what have we done? We have built Flight Deck, which essentially is our flight deck recorder for operating theatres. It's an intelligent AI-driven ambient voice capture piece of technology that sits within the operating theatre and provides a real-time dashboard back into the room, as well as monitoring stations outside, that provide the transcription of the conversations that are having segmented speech, and sentiment analysis. Really important. So live in the room in real time, there are nudges to suggest that the sentiment is positive, negative, or neutral, and behaviours are slipping potentially. There's lots of keyword classifications that have been put in as well to help with nudges where protocol that's been built into Flight Deck hasn't been heard. So for one of our pilot sites, they're very interested to look at their swab count process. They had errors across their swab count process. Flight Deck, in their instance, has been built to really analyse what's going on in that space. And I'll show you a dashboard shortly, just one moment. Of course, it then creates a library of transcripts for the organisation to go back and learn from. But in fact, it's that real-time capture in the dashboard in the room that's proved most poignant and useful and impactful for the staff on the floor there. Next slide. Thank you, Amy. And again, thank you. Here it is, working in an operating theatre in one of our pilot sites. And the point is, you can't see it. It's frictionless. It's not in the way of everyone getting on and doing their role. It should be an enabler to enhance or improve performance, behaviours, and could deliver insights that are meaningful to the team in the moment. And that's exactly how it's been designed to be used. It's non-intrusive and doesn't add friction. In fact, what we're stages we're at now is how can we actually start surfacing this in context of the patient's record within the core electronic patient record. So really looking again at how we can iterate upon its standalone qualities and impacts that it's delivering back. Thanks, Amy. This is the live dashboard at one of our pilot sites. So within the operating theatre, they'll be able to see this on a screen. And again, they can customise this to their own view. But the most important thing that's come up time and time again has been the ability to see that graphical representation of the sentiment in the room, and a sentiment is dropping off into a negative space, being able to look at what's going on and what's happening in the room there. Action items, questions, topics are all caught and segmented as well, and these have proved useful. Various different use cases want to focus on various different parts of the dashboard. And on the right hand side, the compliance aspect that I spoke about earlier, particularly for looking at the protocol around swab count in this particular example. Again, being able to nudge in the real time what has been missed or heard or not heard as it was. In one of our very early pilots on part of our beta testing, this had been live not an hour within the operating theatre before the staff within the theatre decided they were all standing in the wrong spaces, they had the kit in the wrong place, and actually could improve the way they communicated with each other by some minor amendments about where things were being done in the room. And it was lovely to watch that organically happen without getting in the way of the core business at the end of the day. Next slide, thank you. So last, just to finish on, this was built really with that operating theatre and that second victim syndrome in mind. How can we really affect and shift the dial in terms of moving to that system learning and be able to put data, as we learned from our HIMSS journey, in the hands of clinicians who are best able to interpret and change and make and better outcomes. What we've learned very recently, though, we've had a pool to pilot in the space around virtual care, telehealth and urgent health, actually being delivered via some of the big 111 providers, is to use Flight Deck less in that in-person care scenario, but more in terms of plug into the phones. What can it do around that prompting? And again, that live in real time nudging to do the right thing. And again, can be taught the protocols that are around safety netting and various other things that want to be looked at. Again, all in the mind of what what are those human factors that are impacting outcomes, and how can we surface those and analyze those? Thanks, Amy. I think that's us done. And really happy to take any questions. And there's no ask here from us. We're always out looking for development partners and people interested in using, drawing this down and looking at how it might be utilised for different use cases. Hence the recent pivot into telehealth. But yeah, happy to take any questions. Thank you, and thanks for your patience with the faults at the beginning.
Thank you so much, Amanda. That was fascinating and really interesting to see the crux of the challenge that you're trying to address, which is that safety and that, you know, do no harm, how to enable best care. Really interesting, the analogy, the comparison with the aircraft team, actually. So thank you very much. Are there questions from the room, thoughts or even feedback for Amanda? Stunned silence. Okay, in that case, Amanda, would it be okay to share your contact details in case people have questions and want to follow up later? And a comment from Chris in the chat. Really nice to see something other than a one-to-one consultation style ambient AI. That theatre one is brilliant. So much work on human factors this would help with. Yeah.
That's great. That's what we think. Thanks, Laura. Thanks for the opportunity to speak to it. Oh.
No, was that a hand up, Alistair? Was that it's gone down again? Okay, I assume not. Thank you very much. So in that case, that brings us to the end of the supplier demonstrations. We had thought about going back into breakouts to kind of have a discussion about what further questions or support people might need in terms of introducing ambient voice technology in scribes. But I am aware it's been quite a long day, and we do recognise that people slip out as soon as we say the breakout words. So please do add your thoughts to the link that was put into the chat earlier. We're really keen to capture where people think this would be useful, but where the concerns are, so we can stand up appropriate support as and where we can. We've also, thanks to Amy, put in a link in the chat for a feedback form. Again, please do feedback on this event and ideas for future sessions that you would find useful. I'm keen that this is a series to think about how we can effectively but safely deploy AI across a range of different settings and clinical areas. So really keen to hear from you as to what would be useful. We will stay here now, so if there is comments or things you'd like to flag, please do so. But otherwise, please fill in the feedback form. And thank you very much for joining us today. Oh, and Sarah's put the mural link into the chat. Thank you, Sarah.